I'm Megan Chrisman, a registered nurse in the psychiatric field. I work with children diagnosed with mental health illness and behavioral issues. Today, I'd like to discuss a safety concern that could be happening in your psychiatric facility and introduce you to a study idea that may be beneficial to your clinical practice area. In 2017, it was shown that children and adolescents receiving outpatient mental health services increased from 9.2% to 13.3% between 1998 and 2012. Introducing antipsychotic pharmacological intervention has grown immensely in the past 2 decades, eliciting the need for close monitoring of side effects. A patient safety concern in mental health across multiple psychiatric facilities are nurses not noticing or recognizing extrapyramidal symptoms early on in patients being treated with antipsychotics. Each complication related to EPS can lead to severe illness and recovery, and in the worst case scenario, death. My workplace does not have a policy or assessment form that evaluates the possibility of our children displaying EPS. In 2017, Racimos and Liebout conducted a study that indicated between 1996 and 2001, the percentage of new prescriptions for antipsychotics in children increased from 6.8% to 95.9%. The 2013 report from the Agency for Healthcare Research and Quality states that an antipsychotic prescription for children aged 13 or younger grew more than 7-fold and more than quadrupled among adolescents aged 14 to 20. Side effects are associated with medication non-adherence. As quoted by Stomsky, Morrison, and Meehan in 2016, non-adherence has been associated with increased rates of relapse, rehospitalization, and self-harm. Stomsky, Morrison, and Meehan suggest that administration of assessment tools evaluating patient baseline, then again at regular intervals, may make it easier in recognizing adverse effects. The first strategy to decrease the incidence of the amount of neurological dysfunction is to simply inform the patients of side effects. Med review with the patient could be completed weekly with the nurse. This could be measured by the amount of forms done in the chart. A patient survey at the time of discharge could also be conducted, asking whether or not he or she felt they understood their pharmacological treatment plan. Supported by the Joint Commission in 2016, measurement-based care allows the organization to determine whether what they are doing is having a positive and significant impact on the individual served. The second suggested strategy to recognize EPS is by using simulation technique. We can implement an educational session about 30 minutes long regarding antipsychotic use. Knowledge can be measured by an end-of-course exam. The last suggested strategy would be to provide instruction on the use of AIMS assessment tool. Nurses will be able to conduct an appropriate evaluation with a patient-prescribed antipsychotic. In 2017, Abdallah, Khan, and Marini conducted a study to improve the health monitoring of patients consuming antipsychotics in the hospital. They compared baseline results to results at the end of the cycle, proving that an organized assessment tool is effective in continuing quality care of those prescribed antipsychotics. I will utilize the model for improvement according to the Institute of Healthcare Improvement website. My idea is to begin a Plan, Do, Study, Act cycle. The aim is for nurses to recognize early stages of EPS by utilizing an assessment tool. Will the use of an AIMS form be beneficial to patient safety? It is predicted that the use of an assessment tool will lead nurses in recognizing EPS in hopes to catch early neuroleptical dysfunction and treat patients appropriately. The test will be ran for a period of 3 months in a 12-bed child and adolescent mental health unit. We will measure the percentage of assessment tools completed for patients on antipsychotics weekly during treatment team and identify whether there were any EPS incidences. The admission nurse will be responsible for completing the first assessment for involuntary movements if the patient is already taking antipsychotics prior to admission. The physician will be responsible for flagging the chart if he prescribes an antipsychotic during the patient's stay on our unit. The RN will complete an assessment tool before patients begin antipsychotics and then reevaluate the patient every 2 days. This is because signs and symptoms of adverse effects develop between a 24 to 72-hour period following the administration of an antipsychotic. Nurses are to document their assessment results while charting, as well as put the completed forms in the patient's chart. We will look at the results indicating how often AIMS is being utilized. We will observe if the incidence of patients showing signs and symptoms of poor neuroleptic functioning are found due to the assessment tool. If this PDSA cycle is successful, we will continue utilizing this tool and share the results with local psychiatric hospitals. Every organization is unique. To make a positive change in your mental health facility, it is crucial to find the baseline, evaluate outcomes honestly, and to share the findings. There is no better time than now to create a positive change. Your patient's life depends on it.